The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. I'm Gary Swartz with the American Academy of Home Care Medicine, and welcome to this afternoon's Plan of Care Basics webinar. The purpose and objectives for this afternoon's webinar is to provide the definition and overview of the need for Plan of Care, to describe the current services codes, new codes under development, and proposed legislation to produce the sustainable growth rate fix, and that would modernize the Medicare payment. That includes references to the Plan of Care. To describe evolving practice standards, for example, patient-centered medical home, that again includes reference or requirements from the Plan of Care. And to describe the Academy resources and advocacy to support your practice and the field. As we discuss the elements of the Plan of Care over the next few minutes, I want to let you know that we will collate literature on each of the elements and post that to the Academy website, so that's available for your reference as to each of the individual elements, and I'll mention that again as we get into the slides. In the description for the webinar, there was a reference to meaningful use and the Medicare incentive programs. Those relationships will be mapped out for you and also posted, including screenshots from systems, how to document the elements from the Plan of Care that would also satisfy various meaningful use requirements. Issues we discussed today will be presented at the annual meeting. There's still room to register. The early bird registration is open through April 11th, and of course registration continues after that through to on-site registration, but would encourage you to make use of the early bird availability through April the 11th. The need for the Plan of Care. Of course, as you know, as clinicians and practice management, there's a clinical requirement for the Plan of Care. As relates to the regulatory and coverage requirements, the Plan of Care is not described with great specificity in Part B of the Medicare program. We do know that there is discussion on the Part A side, and we'll talk about CPO in a moment. However, codes under development and evolving standards requirements describe a Plan of Care. So the Plan of Care is going to become much more a focus of code development, coverage, payment systems, and standards over the next year. And so that's the purpose of this afternoon's webinar. We will also have a follow-up webinar in the fall, building on this one, and also information that's gained during the Medicare rulemaking process this summer. I would also note that the majority of home care medicine practice touches upon Plan of Care in one form or another, and we'll see that in the next couple of slides. And then finally, as an organizational approach, I would look at the Plan of Care and related standards as a way of developing service and practice development, and also relationship development to grow your practice, support your organization, your services, and to assist your practice operations. Turning to the evaluation and management services, their Plan of Care is noted in the house call codes, in CPO, Care Plan Oversight Codes, and the use of that ranges across practices in the Academy, from involvement with home health agencies from anywhere from single digits to almost a very strong relationship of patients having home health episodes at any given time. So that ranges across the practices, but is some element of the practices across Academy members. In 2013, we saw the introduction of transitional care management services, the 99495 and 99496, that include plan of care requirements. And then under development this year for effect coverage and payment 2015 are chronic care management services. There's sort of a two-track approach going on right now. There's a regulatory movement, and there's also legislative development, and we'll discuss those in a moment. So again, the majority of your services and practice revenue in some way or the other relates to services that at their basis touches on the patient's plan of care. These are the evaluation and management services, again, the current services that are in the fee schedule and covered in the CPT manual and covered by the Medicare program. There are new codes and evolving models coming under development now. There are shared savings programs such as IAH and others that require a plan of care as part of the shared savings program, and those are increasing around the country. And then finally, we have private health plans that some members have as a part of their practice to a greater extent than other members. And some have a great deal of activity around transitional care management services, health assessments, and chronic care management services, again, which touch on the plan of care. Just another way of looking at it, the care plan with the current services, the evaluation and management services, CPO. One thing I didn't mention previously, the preventive services, the annual wellness visit, forms the basis and as the development of a plan of care from the patient's assessment, and again, the transitional care management. The new services and payment models in the Medicare final rule for this year was discussion of chronic care management services. Codes are being developed right now. There was a group of codes that the AMA CPT panel forwarded to CMS and was adopted last year. That was not accepted for coverage for 2015. Medicare alternatively has proposed its own G code for effect in 2015. Academy members and others of different specialties around the country may be receiving or asked to participate in a survey to value that code that's under development by Medicare. And then we will know further later this year when the proposed rule comes out this summer, and then with the final rule later in 2014, which codes for chronic care management services to pay for your both your face-to-face and your non-face-to-face services that are outside of the existing evaluation and management codes will be adopted for coverage and payment for 2015, and at what payment level. And that's a process right now that the Academy's involved in. Also, there's another code that's under development, Advanced Care Planning. You may also see information about a survey underway to value the work and resources involved with Advanced Care Planning Code, which just touches on one of the elements of the plan of care. And again, this would be a code that would be used beyond the content of existing evaluation and management codes. In essence, would be an add-on code, additional a code to pay for your time and services that are beyond the basic house calls. And for the office-based clinicians, it would go beyond those CPT codes for office-based services. Under consideration right now in Congress are various proposals to provide a fix to the annual issues related to the sustainable growth rate formula and the the cuts that always threatens to the Medicare fee schedule. A process that has more momentum than usual is underway this year, and actually Constance Rao, the Executive Director of the Academy, is on a call right now with facilitated by the American Medical Association that is discussing the status of that legislation as we speak. That legislation, one of those bills that we've mentioned in the e-news, House Resolution 4015, includes some additional payments outside of the fee schedule. The fee schedule would be increased moderately each year. There's provisions for merit incentive payments that touch on quality and reporting, and that would replace the current incentive programs. There's also an element for alternative payment models. That would be, in a sense, a shared savings-like opportunity for practices to participate to earn additional dollars beyond the fee schedule. And then finally, there would be an opportunity to participate in patient-centered medical home or similar settings to earn additional bonus payments outside of the fee schedule. And we'll look at those elements in a few moments. And the Academy is involved with efforts to communicate, to review the literature of the field and to communicate to CMS that it is important to take into considerations the services of the home care medicine providers and Academy members and their effectiveness, and not to have elements or requirements that are not relevant to your patient population or that would unduly raise the cost of care without having an impact on the quality of care and utilization. Many of you may have seen a New York Times article this week that touched on that reports discusses a study on the patient-centered medical home model and whether that has produced cost-effective results or not, and what are some of those findings from that study. And again, that's part of the literature and the evidence base that the Academy wants to make sure that is known in the development of standards that would be required for additional bonus payments from the Medicare program or payments for the chronic care management services mentioned from the left-hand side of this table. And then finally, many of you are well aware or participating that many private health plans require patient-centered medical home certification in order to be part of their networks as primary care providers. And that is an issue we're aware of, and again want to influence the managed care marketplace as well as to appropriate standards for home care medicine services. So taken together, we see the evaluation management services, the new codes under development, the chronic care management services, and advanced care planning for effect 2015. That are both discussed in the Medicare final rule for this year, for next year, discussed for effect for next year, and also that are being considered in Congress right now. And each of these proposals or services that touches on includes reference to a plan of care. I want to take a step back in terms of documentation and compliance, and sort of the starting point of everything would be the basis for the home visit, and just wanted to present again the requirement for physician presence, and as relates to homebound status, that the services under the house calls do not require Part A requirement of being homebound. It's rather a different description for the house call services, and there is the need to provide the documentation of the medical necessity of the home visit made in lieu of the office or outpatient visit. And again, that should always be placed up front with your history of present illness or at the beginning of your documentation there. Mention the annual wellness visit as one other opportunity or area where the plan of care comes into place, and actually this is used or intended to develop a plan of care for the beneficiaries. And you can see this is taken from the Medicare coverage manuals, that all referrals in a written medical plan must be included in the documentation of the annual wellness visit. The annual wellness visit is something that the Academy worked on to advocate in different areas with different Medicare administrative contractors to assure that the service for your patients would be covered as well as in the office setting. Some of the services that were described for development next year in the chronic care management services, earlier iterations of the proposals included requirement of an annual wellness visit. There are some across the geriatric and leadership and other fields that thought that a requirement of an annual wellness visit for your populations may not be required in order to be covered for those comprehensive chronic care management services. So we're keeping an eye on whether that would be included or excluded. But do know that on an ongoing basis, that is a covered service that is available to you. And it can also be used when there is for efficiency reasons, when you are also seeing the beneficiary for a medically necessary reason unrelated to the annual wellness visit. Both can be documented and submitted without duplication of the documentation, but distinct documentation for the reason of the medical necessity visit and for the annual wellness visit, and submitted with a 26 modifier to Medicare and with payment for both services. Care plan oversight involves, by definition, the development of and oversight of the care plan. Some of those requirements are provided here on this slide. To note, the formal 485 is no longer required. You may be still completing those or something that looks similar from in your relationships. We will also post a side-by-side comparison of the elements of the 485 and alternatives that would be required to meet the requirements of care plan oversight. And again, this slide just continues on the requirements for care plan oversight. Turning back to care plan specifically, care plan is based on physical assessment, mental assessment, cognitive assessment, functional assessment, and environmental assessment. In reviewing the literature on plan of care, again, we found that there was not great specificity in terms of definition under Medicare Part B. This was reviewed a year or so ago. And again, this is changing now with the development of the chronic care management services and the standards for practice that relate to the coverage and payment for those services for 2015. So the Academy, a group got together as part of the development of the Academy's field guide to home care medicine to define a plan of care for the home care medicine patient population. And we'll review those elements. So the elements that were developed by that group included the following: patient goals and advanced directives, prognosis and life expectancy, inclusion of a problemist, cognitive functional assessment, and review of decisional capacity, symptom management, medication management, environment safety evaluation, caregiver and family assessment, and then integration and coordination of community and social ordered services, home health, DME, hospice, and community-based services. So this was from the consensus panel of what would be the elements for an appropriate plan of care for the home care medicine or house call population. That is posted and available through the Academy website, and there are also resources linked to each of these elements. What's under development now with the codes for chronic care management payment, again effective 2015, this is sort of the elements that we're seeing on that list for inclusion as plan of care and plan of care requirements. You can see that it differs a little bit from some of the cognitive areas and environment assessment that would be most applicable to a home care medicine population as compared to a more general Medicare population. Again, a problem list, expected outcome and prognosis, measurable treatment goals, symptom management, planned interventions, medication management, again, community social services ordered, and the coordination of home health, DME, hospice, community-based services, how the services of agencies and specialists will be directed and coordinated that are not related to the practice or embedded within the practice itself, and then identification of the individuals responsible for each intervention, requirements for periodic review, and revision of the care plan as necessary. Again, as mentioned, there are resources available to describe tools, documentation techniques, and application and integration of each of these elements into your services. And we will post, have posted that literature and those resources that relate to each of these elements. One thing that I wanted to touch on, it relates to ongoing services in the home. As many of you know, that the Medicare Advantage health plans are now explain about 30% of the services for Medicare beneficiaries. In some of your communities, that percentage could be higher, perhaps as much as 50%. In some of your communities where your practice is established, there could be very little or minimal Medicare Advantage plan penetration, and most Medicare services and beneficiaries are still receiving services under the traditional fee-for-service system, and not in any particular, receiving those services from a particular health plan. But with that continued growth, Medicare each year evaluates the payments and its methodology of paying the health plans to assure that their provision and arrangement of Part A and Part B services, and the proposal for how to pay health plans for 2015 has come out over the past few days, and I just wanted to mention a provision in there that has caught the attention of Academy staff here and Academy members around the country. Some Academy members and others may be providing assessments, diagnostic assessments for Medicare beneficiaries that receive services under the Medicare Advantage plans, and those assessments provide diagnostic results, and those diagnostic results in turn influence the payment that the health plans receive from Medicare to provide services. Medicare has become concerned about those assessments that are used for diagnostic coding purposes that do not include subsequent follow-up medical care or the involvement of a primary care provider. This is the actual discussion in that proposal for next year that describes this concern. And just a couple of sentences from there, there appears to be little evidence that beneficiaries' primary care providers actually use the information collected in these assessments, or that the care subsequently provided to beneficiaries is substantially changed or improved as a result of the assessments. So in essence, what they're saying, and the reason I wanted to include it in this afternoon's presentation, is that essentially this is the opposite of the development of a plan of care and ongoing care of the patient. These are the one-time assessments that, and again, Medicare has become concerned about their use, and that the lack of integration of the results of those assessments to ongoing care of the beneficiaries. And what to do about that? They are considering various options, and one that would include that they could establish a requirement that beneficiaries have a medical visit in a primary care setting within 60 days of the home visit. That was when the assessment took place, in order for the diagnosis from the home visit to be used for risk adjustment. And again, the risk adjustment refers to the methodology through which these Medicare plans are paid. The opportunity here that this concern can be used to leverage your services to provide home-based primary care is part of a health plan network. So if the Medicare proposal there, or that provision that there be follow-up visits within 60 days of that assessment, to me, that would grow the opportunity or the need for home-based primary care providers, academy members, to provide services and be part of health plan networks, and to follow up on that service and to provide ongoing services to that beneficiary. It will also provide you with an opportunity to develop care coordination and shared savings type services with the health plans for their home-limited, high-cost, high-utilization enrollees. So that's a provision, while it seems not to be directly related, perhaps day-to-day to your services or to the plan of care. The way that it connects is that, again, it's CMS views this, that it's really the opposite of ongoing care that's based on a plan of care, and they want to start to go the other direction. And we want to keep our eyes on that and see that that can be developed and encouraged as an opportunity to grow your services in the field of home care medicine, and with the result of better care for the beneficiaries, and of course the appropriate cost and utilization results as well. As mentioned, codes under development require a plan of care, and these codes under development will also require patient-centered medical home or similar approved standards to be met for payment. So as part of the development of these codes, they're not only describing what's required as part of the chronic care management services, they're describing the Medicare beneficiary, or the patient population that would be eligible to receive these services, and then the surrounding services and practice requirements in order to be approved to render and to be paid for these services. The patient-centered medical home came about through a consortium of primary care groups in the late 2000s and 2007. The current status is that there's recognition by many health plans of the concept and the operations of patient-centered medical homes. And that recognition is also emerging within Congress in the Medicare program. And again, that is what the Academy is working to make sure that whatever standards result are tailored to your, or are aware of your patient population characteristics, and to make sure that whatever standards are developed are ones that as many Academy members as possible could meet to be able to render service and to be paid for those services. Across the country, literature suggests that about half of practices have in place patient-centered medical home practices or certification, or that some number of practices have the development of patient-centered medical home model and certification under development within the practice, and that includes Academy members as well. Some impediments to adoption of the patient-centered medical home approach is the high resources that are required in terms of cost, expertise, operations, and currently there's a lack of direct or commensurate payment for being a patient-centered medical home that comes close to matching the cost of developing the practice operations and infrastructure and services to satisfy the requirements and be certified as a patient-centered medical home. What are the characteristics or the elements of the patient-centered medical home itself? That includes the standards that relate to access to care, when and how available, and during and what hours, and what are the after-hours access. What is the continuity of care? Who is that provided by and how is it assured? A definition of responsibilities of the practice, definition and operation of the practice team, EMR, recording and use of patient information for population management. And then again, touching on the plan of care is this next area of planning and managing care, using evidence-based guidelines, identifying high-risk patients, having in place a plan of care, medication management, including medication reconciliation and e-prescribing. So we see that as one important element of the patient-centered medical home, or standards that would develop that would be similar to the patient-centered medical home, again, include the requirement for a plan of care. EHR, using certified EHR technology, and then self-care support, referrals to community resources, tracking and coordinating care, coordinating with facilities and managing care transitions, and measuring and improving performance, and having a CQI, continuous quality improvement process in place.